with patients with congenital heart disease, that is the priority. We also know that if you want to learn cardiac anatomy, heart specimens are considered gold standard, but they have limited availability, especially in developing countries like ours, India, and many other countries. Even cardiac morphologists are not happy. Sometimes they have felt guilty about naming things wrongly. Like for example, here, this is the inferior, but we keep on telling this as posterior wall, and so on and so forth. Models are another way of understanding anatomy. They are useful, but occasionally on many they are inaccurate. Operating rooms are a bit intimidating, may not be for people like Dr. Sasha, but for many cardiologists who are learning, it becomes a problem, exactly what is going on. Echo has its own problems. So what we are left with, angiography again, it's a 2D representation of 3D, and therefore it's not a great tool to understand cardiac anatomy. So then how do we learn? So with the advent of CT, angiography, and cardiac MR, which are cross-sectional imaging, we have got a tool which provides high resolution volumetric data. And most of the time, how we analyze these CTs are by doing multiplanar assessment. And those who have seen CT being analyzed by their radiology colleagues understand that they assess in axial, coronal, and sagittal plane, and then they modify accordingly. But this is something like slicing the bread loaf into small slices. But we know what is the problem with these 2D images. And this picture exemplifies what is so important if you don't look at the three-dimensional structure. And this again shows how 3D improves upon 2D in terms of understanding. So this was the question I asked in 2016, why can't we see this volumetric data if it is there in CT's data sets? My radiology colleagues told, actually you should try volume rendering. So for those who don't have exposure to CT analysis, I'll just briefly tell, in volume rendering, these 2D images slices are stacked onto each other, and we produce a 3D virtual cube, which is then seen by us. And then when we rotate, it gives a perspective of 3 dimension. So I was very happy. This is what volume rendering is. And I think most of people who have seen CT being analyzed would have seen some or the other image like this. So I asked, please show me inside the heart. And that was the thing I was looking for. So I was told that it won't be possible because VRT doesn't permit viewing inside the heart. And that was the problem which I was facing at that point in time. My radiology colleagues suggested that you should try 3D printed model if you are interested in intracardiac anatomy. So I looked for my options. They were pretty costly. We know 3D printing is possible, more so in last 5-7 years. It has come the long way, but it is quite costly. There are other advanced visualization softwares. They are either too costly or they are not available in a country like ours. So you have options like Xiostation, TerraRecon, 3Menshu, Vitria, which gives a very good intracardiac visualization. However, they are very costly, something like $100,000 to $75,000, and that brings in a significant amount of cost. So I started working on something which I thought would be useful. So I used the hardware, which is MacBook Pro, and a software which is 16-bit Horus DICOM image viewer, which is actually an open source version of Osiris. A lot of people who have used Mac and have seen some of their data sets would be knowing about Osiris. And what was used by me was Horus, which is a free version of that. Now, when I looked upon in this Horus further, I realized that there is something called 16-bit color lookup table editor. And what it does is that it manipulates the data sets that is being visualized into these many color tones. And once we do that, it permits manipulation of the histogram embedded in the CT dataset to allow visualization of the areas which we are interested in. And this editing, I thought, is almost like how you edit your digital photograph in a digital camera. And the results were that this was the prior image where nothing was seen inside. Once we move and manipulate that 16-bit CLUT editor, the intracardiac details were now seen very well, and that too almost using my own laptop and using a free software. So I thought that there is something there is in this technique which should be further explored. So I first used it in some normal hearts, where you can see we are going from left side to right side, and you can see the details of the musculature of the right ventricle is very well seen. You can see the aortic valve cusps, right coronary artery, and this one is my personal favorite, where you can see the right atrium, even the terminal crest and pectinid muscles are seen. I do not think that there is an other way of visualizing these finer structures without going into the surgery or autopsy specimens, and this was possible in patient using a CT. So when I explored it further, we could even visualize the two leaflets of the mitral valve, three leaflets of the tricuspid valve. I could also help some of my students to understand how they do septal puncture for their balloon mitral valvotomy, for rheumatic mitral stenosis, which is quite common in our part of the world. And this is how we can create anterior-posterior projection, right anterior oblique projection, and lateral projection. And you can see that almost all the landmarks which are important for such an analysis are seen here. Now, secondum defect, again here you can see triangle of Koch, tendon of Todaro, coronary sinus, all the rims of the ostium secundum defect are seen. And this, even if it is not used for decision making in a patient, they were quite useful for educating students and sometimes to counsel the patients. Similarly, sinus venosus defect, as you can see over here, this defect is very difficult to understand without having exposure to surgical specimens or autopsy specimens, but this was possible here by seeing that this is that so-called anomalous pulmonary vein, and this is that normally connected pulmonary vein. And this image shows that the SVC is actually having biatrial connection, with this star mark showing the atrial septum actually bisecting the SVC. Now, in another patient where upper muscular VSD could be defined very well, and we could show the relation with the effaced ATL, and we could see the relationship with adjacent structures, and this patient could actually go in for device closure of this VSD without having any difficulty to the conduction system. Now, in another case, double outlet right ventricle with subaortic VSD, we could create these images, which I think are very useful for any surgeon or a cardiologist whenever we are planning for routability assessment of these patients. Similarly, in tetralogy of fallow CT, you could almost show whatever can be seen on pathological specimen, and you can see that even without having access to the pathology specimen, you can explain what is going on and what is to be done. Some of the things which were not clear, as for example here in common arterial trunk, these two arteries are coming close to each other, but it is very difficult to say whether they have a common origin or they have a separate origin till the time you see from outside. But as soon as you see from inside and you have an intracardiac or intraluminal view, you can say for sure that these two have a separate origin. Cross pulmonary artery also could be seen very well, and you could demonstrate that how these orifices are crossing each other. There were some other things which could be clarified using the similar technique, where this subarterial, subtruncal interventricular communication had a muscular ridge, which could be further clarified using a similar CT-based virtual dissection, and again using Horus, which is a free version of the software. Mitral paravalvular leak, again, it could show what is the relationship with the paraprosthetic valve at the mitral position, and this would guide the interventionist how to access or puncture the atrial septum to get into this if they are closing the defect with the device. So this quest of getting inside the heart and visualizing it led to this paper, and this paper
Welcome
had
to this introductory video.
This paper had all the technical details how to achieve this virtual dissection. Since this video shows all the details, I would let it run and let people listen. And after the presentation, I'll give a live demo of one case, how actually it is done.
Virtual cardiac dissection. To achieve virtual cardiac dissection on a Mac PC, using our technique, all you need is Horus, an open-source software and a good quality ECG-gated CT angiogram. First, the CT dataset is imported. The CT dataset is then evaluated for quality of chamber opacification and freedom from artifacts. For example, in this case, all the cardiac chambers are well opacified and there are no motion artifacts. The dataset is then subjected to 3D volume rendering, which is inbuilt within the software. This volume rendering produces a virtual cube of volume by stacking cross-sectional images in 3 orthogonal planes. The virtual volume thus created can be rotated in desired views and projections. The rotation of the volume is guided by the changing coordinates located at the right lower corner of the screen and the direction cube located at the right upper corner. The cube can be rotated to obtain left and right anterior oblique projections. Similarly, cranial and caudal tilt can also be replicated. The 3 orthogonal planes can be moved to clip edit the volume, making it possible to look inside the heart. As is obvious here, although it is possible to look inside the heart, none of the details of intracardiac anatomy are discernible. Now, let us see how to perform virtual cardiac dissection from this virtual volume. This can be achieved by using 16-bit CLUT editor. Once again, the CLUT editor is built within the software. Application of 16-bit CLUT editor provides a color map which can be manipulated to visualize intracardiac anatomy. The color map can be shifted in right, left or up-down direction. In addition, individual points on the color map can also be adjusted to further improve the details of various cardiac structures. As is highlighted in this example, the adjustment of color maps optimizes visualization of intracardiac anatomy. These settings of color maps can be saved as presets. Use of these saved presets allow virtual cardiac dissection in a much shorter time. As shown here, the details of intracardiac anatomy are obvious within 30 seconds of applying the preset. The images thus obtained provides much refined visualization of intracardiac anatomy. This virtual volume can then be edited for clinical decision-making. The virtual volume can be rotated and clip-edited to illustrate various aspects of the cardiac malformation. As shown in this example, visualization in the left anterior oblique projection with cranial tilt provides all the relevant details required to plan surgical repair. In this figure 5a of the manuscript, the intracardiac anatomy of a child with double outlet right ventricle is demonstrated in antero-posterior projection. The red dotted line represents the interventricular communication in subaortic location. The left anterior oblique projection with cranial angulation corresponds to figure 5b of the manuscript. It shows the relationship of the interventricular communication with aorta and tricuspid valve. The red-colored double-headed arrow shows the anatomic location of the interventricular communication. On the other hand, the yellow double-headed arrow is the line of surgical closure. Thus, virtual dissection shows why it is more appropriate to use term interventricular communication in place of ventricular septal defect in the setting of double outlet right ventricle. The advantages of such a low cost and easy.
So what I realized was that it is quite possible to do such kind of virtual dissection on almost any good quality CT scan. But the next question was, is it really 3D? Despite virtual dissection, the appreciation of the third dimension was suboptimal, relying largely on lighting and shading of the data set. So then one thing led to the other thing, and I started asking this question: do we really have 3D vision? I asked my wife, who is a retina specialist, and she told me, your eyes cannot see 3D. Even though we are 3D, living in 3D world, what we have is a stereopsis and actually not the 3D vision. Thanks to our two slightly displaced eyes, we have a slightly different perspective of same image, which is then sent to the brain. The brain then merges these two images to create one, and that is how we have the depth perception, which is actually not the 3D, but it is more like stereopsis. So the question was, can we replicate stereopsis on monitor? The answer is yes, but only if we trick the brain by using virtual reality, augmented reality. But again, you would need virtual reality headsets for stereo vision and a space of around 6 to 8 feet square, where you will apply that and you will have to convert the data set into virtual or augmented reality compatible softwares. So then I was searching for another easy alternative, and what I came to know that there is something called Anaglyph stereo vision, and thereafter I came to know that we can achieve stereo virtual dissection. Now the basis of this Anaglyph based stereo vision is that you create two sets of the images, one which is red colored and one which is blue colored, and then you use Anaglyph glasses. One eye is having blue glasses and the other eye is having red glasses. The red glasses will filter all the red rays which are coming, and the blue will filter all the blue rays, and therefore we are actually tricking the brain to create two perspectives of the same image, and you would then get a stereo vision which will allow you to see the depth within the same image which was created, and you can convert it into stereo vision. Now in this example, I think if you have to see the depth in this, you will have to use red sign Anaglyph glasses. I'm sure you don't have, but whenever you have, you can see this recording and you will be able to appreciate the depth within these images. As you can see over here, the virtual cube is duplicated. One is red image and the other is blue image. And this depth will be automatically seen as soon as we wear red sign Anaglyph glasses. Now this is another example of superior sinus venosus defect, and the same thing will happen once you have that. You will have automatic depth perception without using any expensive hardware or a software. Those Anaglyph glasses cost less than $2 and they are very easily available. Now, more advantageous is as it's written over here, if you slowly move your head towards left and right, backward and forward, you will appreciate the depth much more, and you can understand the perspective without actually changing or rotating the data set. Same thing, almost any image which is virtual dissection image can be converted into stereo vision, and I will show in demo how it can be done. You can even create some of the videos, like for example here, this is a rheumatic heart disease with mitral stenosis, and once you see it in with those glasses, you have a very magnificent view of the left atrium and the mitral valve. The next question is, do you always need a computer to realize this stereo vision? The answer is no. Instead, these stereo images can be easily shared by electronic methods using email, WhatsApp, or using QR codes. Even for that matter, if you have a QR code scanner, you can scan this barcode right now, and this image will be transferred to your phone or your desktop. And thereafter, whenever you have those glasses, you can try. This will show you the stereopsis and depth perception within the same image. We can even print these images and share these stereo images with whosoever you want to. But the difference would be that the images, when we are printing, it's slightly different from what we see on the monitor, because the lighting conditions of the monitor is high quality, because the monitors emit a light while On a photograph, it is dependent on the ambient light for better visualization. However, if anybody is interested, you can see these images. I'll be providing a link to Google Drive, where from you can download all these images and relevant documents, and you can use and see how effective it can be, even when it is printed on a photo paper. Now, based on this experience, I again published along with my wife a technical paper where we have explained how this stereo vision can be achieved just by using a simple click of a button, and it will take another 10 seconds to convert any virtual dissection image into Anaglyph stereo virtual dissection image. Now, I have explained how these things are done. I think if we use such methods more and more, we can avoid using all this, and we can rather go on to this more realistic use of these images. I'll straight away go. You can replicate some of these. This is a virtual surgical exploration of superior sinus venosus defect, where we are trying to open the right atrium, and you can see this is the tricuspid valve orifice. This is additional fossa ovalis defect, and this is the defect in the sinus venosus region, with this is the anomalous pulmonary vein which is draining over here, assuming that the surgeon is standing on the right side and this is the left side of the patient. So this is how we can explain it to the trainees who may not have chance to get exposed to surgical units often. Now, patient education and counseling, of course, it can be used. We don't need to print these models, and I think this serves a very good purpose. And these are only 2D representation of those 3D models. If you can do the same on Horus, you can actually rotate and show whatever you want to show. Pre-operative planning, I have already emphasized. And I think such kind of virtual models based on virtual volume rendering are much better than virtual models based on surface rendering, because volume rendering is much superior computationally, and it is now possible using newer tools and techniques. Pre-procedural planning, I have explained how it can be used. It can also be used to clarify some of the anatomical issues which are lying, and based on these images also, we have published a paper to clarify anatomy of common arterial trunk, and I found it very useful while we were digging out details of those anatomical lesions. Now, this was one of the case where the systolic, during the systolic phase, the truncal valve was actually obstructing the pulmonary orifice, and then it was causing pulmonary obstruction in this patient who was 6-year-old. And in this CT, we could really see exactly what is happening. As you can see over here, that this is the truncal valve leaflet, which is obstructing the pulmonary orifice by more than 50%. And that is the reason why this patient had protected pulmonary vasculature even at the age of 6 years and could be operated successfully with a very good surgical outcome. Superior sinus venosus defect, again, using the same technique, we could use in different subsets like superior caval vein override versus no override. And I think there is no other way of understanding such complex 3D malformations without resorting to any such modality. You can use 3D print, but I think there is a lot of cost involved, and you can use commercial softwares, but I found it useful because there is no cost as such. Again, the same thing, you can compare it with different lesions, understand, and I, for the first time, realized what a superior sinus venosus defect is and what does it matter when the surgeons are closing or when it is closed interventionally. Possible future applications, if this can be merged with the live fluoro, then it can be very useful. We know it is possible, but somebody probably have taken it up. Stereo vision improves cath lab experience that has been shown previously in cardiology as well as in neurosurgical applications where people have found stereo vision as useful. And the way I have shown, possibly this also can be adopted in some of the procedures. So in summary, virtual dissection provides excellent visualization of the intracardiac anatomy. It provides patient-specific anatomy in user-friendly views, and stereo virtual dissection further enhances the third dimension without using very costly software or hardware, and it eliminates the need of costly software and workstations. So take-home messages: 16-bit CLUT editor-based virtual dissection and stereo virtual dissection using Horus, an open source software, is an attractive, low-cost, easy-to-use, and user-friendly technique for visualization of intracardiac anatomy in select cases with good quality CT data set. Thank you so much for patient hearing. And if somebody is interested, this is the link which is there, which will allow you to take to my Google Drive folder, which will have all the relevant papers, images, and this particular video, which is running over here and which I ran in the middle of the presentation, which tells you how exactly it can be done. Thank you so much. Dr. Shasha.
Saurabh, I think we can move on. I think we will
Dr.
do ourselves. Hi.
Yeah.
Many congratulations. Yes, many congratulations for your talk. I think was amazing, very covering the entire world of 3D post-processing tools. I think you clarify some of the aspects or simplify for beginners, let's say people that want to approach not so skilled or not so connected to the expensive world of softwares related to the 3D aspects. So I think that we can move on, and I don't know if there's any questions from the audience. We can briefly have a.
I think there are some questions. By Dr. Adrian, who asks. Thank you, Dr. Adrian, for your comments. I think it is a free open source software. So if you want to use for clinical reporting purposes, I do not think as of now it can be used in your part of the world possibly. But over here, where the regulatory requirements are not so strict, we sometimes use it. And regarding the clinical outcomes, I haven't done systematic analysis. I'm in the process of doing it. But as for any other visualization technique, to show a greater impact would be a difficult task, because it is more in terms of understanding of people who are dealing with the patient and treating, rather than actually making a huge difference in the outcome. Dr. Aurelio can help me in that question further.
I think that if you want my opinion, so it's very hard to prove some of these the impact on patient outcomes, because I mean, we have already some standardized approach for some of the treatments, and those tools are already in the clinical workflows, and you basically don't know. So it's very hard to differentiate. There are some studies that proves that it's very useful, for example, for DRV, or that some of these aspects are very useful in patient involvement and patient, let's say, patient parents involvement during the counseling and during the consent before a procedure. But of course, it's very hard to prove that in a large scale, so in large numbers. My opinion is that some of the tools they are so clear, so easy and straightforward, that sometimes they get inside the clinical routine as soon as they are available, and that you will probably need to prove that to prove their efficacy. So they basically get immediately into the routine.
So Dr. Aurelio, we can do two ways. One, I can demonstrate a case, or you can just show your presentation, and at the end we can do a case demonstration just to show few of the steps, like a stereovation I just wanted to show.
Okay, I think we can go with your case, and I have some other case depending on the time we have, and then on the interest of the people or the attendees. And I think your very first case might be very useful to show the way you get to the 3D virtual model.
Right. So I'll share my screen again, and I will. So I think my Horus screen is visible now.
Yes, it is.
Okay. So this is one of the same patient which I demonstrated in the video. I'm using the same case so that I can show live exactly how it is done. So once we have checked the quality of the scan, we just hit this 3D viewer and 3D volume rendering over here. So normally this 3D presets will take us to this one of these mid contrast or image like this. After that, our job is to post process it. I will just zoom it up. No, so this is a virtual cube which we are dealing with. And these boxes, these dots will allow us to get inside the cube as I was showing at that time. And as you can see, now we are seeing inside the heart, but it is full of contrast. Now we bring in our 16-bit CLUT editor. So it comes from this CLUT. If you can see over here, this is 16-bit CLUT editor. And once we do that, as you can see, this is the whole, it's almost like a digital photograph on a digital camera, a professional camera. This is the histogram, which has whole of the scanned area spread out. And the area under this curve, this color map, is the one which is being shown here. So once we manipulate this, I'm manipulating in front of you. And if you can see over here, the densities have started changing. And now I've moved this side. And as you can see, things have started appearing inside the heart. So this takes some time to practice. This takes some time depending upon how is the data set and what disease we are talking about. But you can see some finer details here, which can be further modified using, either you spend some time or you borrow some of the presets. So I have some presets within my system, and they are all saved here. For example, how do you save these presets? If I am happy with this, then I can save this as preset from here. Sorry. And the good thing about this is, if you have made a mistake, you can do Control Z just like you do in a Microsoft Word, and it will go back to the previous step. So if you have made two curves which are by mistake, you can just do Control Z, and it will go back. So that is another good thing about this software, that it allows a lot of freedom of making mistake and then correcting on its own. So that is how now you can save these presets from here. You can say select 3D preset or save current state as preset. So if I save it here, it will go in one of the folders, and these details I can share with anybody who is interested in going in further. For the time being, I'm just demonstrating how application of preset will in real time change this virtual data set. So for example, in this, I'm just applying this preset, and once I apply, it will take less than 30 seconds to convert this image to what I was showing in the video. So I think that once you have done 20-30 cases on your own, it becomes pretty easy to apply those presets on any of the CT data sets, and then you are almost good to go. Afterwards, it needs some fine refinement of the data set and these curves to make things better. And you have to realize that these structures like tricuspid valve chordae, they are thinner structures, so they tend to disappear. They tend to disappear if you are not careful. So depending upon what structure you are interested in, you have to change your data set. Like for example, here, now you can see the tricuspid valve in closed position. This is the papillary muscle with the tricuspid valve. And these are the chordal apparatus. This is that interventricular communication we were talking about. And this is the coronary orifice. And I think almost all kind of views can be made like this. And this I have already explained during in that video. Now, anybody who is interested, these presets are again in the same folder, in that Google Drive folder, the link to which I have shared, and I will share again. Once you have done this, stereo vision is actually pretty easy. It is actually nothing. It's just a kind of illusion which is created by the software, but then it's quite an impressive illusion. and I will show you how. I hope you can see the bar and my mouse right now. If you can see here, it writes stereo. Once I click it, it has converted the image into 2. You can see over here that this cube has been duplicated into a blue cube and a red cube. And once you see this with the Anaglyph red, blue stereo, those glasses, then you will see the depth immediately. This is all I wanted to share, unless there are any specific questions which I need to answer in this demonstration.
Thanks a lot, Sir, but that was amazing. I think that you clearly demonstrate that you can do it easily at your with the low cost approach, and I think that it's very interesting to spread these tools in the entire world, so in many different parts of the world where the access to these software, some of these softwares, so the advanced tools and powerful computer can be limited, and I think that is a very important message to leave. So I think if there's any other new questions you want to have a look and answer first, which is I think is
I think one important question is that is it available on a PC? So Mac, this Horus software and OSRX is only for Mac. However, almost similar CLUT-based editing can be used on any system. I mean, even in any workstation which is available with the CT, actually they have that CLUT editing. It comes by a different name, but if you go into VRT gallery, actually that can be done. I have tried in the system which is available in our sister department, cardiac radiology, but I found it less user-friendly. So I stick to Horus for my personal uses.
I think there's a question about micro-CT. I think that, this is a pathology tool. The amount of data when you work with the micro-CT is usually larger than the data we currently use with a conventional coronary CT angiography. So I think that this question has to be asked to people from pathology, pathologists. But I think that, from my experience is limited. It's very difficult to manage a large data set, more than many gigabytes of data with let's say with a personal computer or a laptop from a Mac. So I strongly suggest to refer to your pathologist if they have a micro-CT. And what else? There's a question about I think the TGA model on the 3D printer. How do you print that? Do you want to comment on that?
I just see that question.
It's one of the last one.
Okay. How do you print TGE model on the 3D printer?
I think TGA.
This cannot be, the virtual models created by volume rendering are not printable models. For printing, you need surface rendering or some of the other formats which are for 3D printing. So this is exclusively virtual as of now. Maybe in the future, there is a possibility, but Dr. Aurelio can correct me if I'm wrong, but I think virtual rendering is much more, it includes much more of the data. So the credibility of the image which comes out is better than the surface rendering.
Yeah, absolutely. We can beautifully reproduce the virtuality in the virtual area that can be immersive or not, using, the stereo tools, or rather than a proper immersive vision with the visors. What I would like, the TGA anatomy, it's very rare to scan a TGA at birth. So we have very limited data sets on this topic because, echocardiography is doing beautifully. We scan very few ones for very specific coronary queries. What I would say is that it is interesting to have this data set as much as possible, because the surgical simulation on 3D printed models with the specific materials and I think Sasha could add something about this. They had a webinar on this topic, so the surgical training on 3D printed models specifically for TGA or complex congenital heart disease can be very, I think is definitely something validated in terms of training, and that will probably increase, especially to train young surgeons, because it's very hard to have access to the theater for very young surgeons to have a huge experience in casuistic. And I think like the like a Formula One Formula One like Hamilton is doing is a Formula One Grand Prix before the real race, just many times before in his simulator. I think the surgeon has to do the same, and this 3D printed model those could be very useful from this point of view. I'm not a surgeon, so I can't tell how much they are reliable from this point of view, but there are some papers for sure, and they proved already some accuracy from this point of view. Okay, I think we could move on.
Yes.
There are so many compliments, many positive comments for you. I think you will have to read through that, and I will just go through my very short presentation, because I think, I mean, I work in the cardiac radiology, and of course the 3D let's say the 3D tools are very welcome, and we have a specific software in our lab that we can use. I will switch to my presentation if you don't mind.
Yes, please,
okay.
please, Dr. Aurelio.
And so I don't know if you can see my screen. So what I will talk about today is just to highlight that these tools that we already seen in the previous presentation are, of course, commonly integrated in the routine workflow for some of the disease, and we have a specific and dedicated laboratory that is working on the data sets. So is merging CT and MRI, is doing some more advanced analysis on these images to get the best quality data set or 3D model, STL, stereolithographic model, and merging all the possible data and giving the surgeon the images in a virtual or 3D printed model. And I think the hollow, the cavitary, so the intracavitary evaluation of vascular structures or the ventricles is routinely applied in our practice, especially for DOV or some intracardiac defect, VSDs especially. Another application which I would be talking today is something that I think is also useful, and it can be sometimes more challenging from the acquisition point of view. So the CT images has to be very with higher resolution, temporal and spatial resolution, to get the best quality images with the best opacification of the vessel. The small structures, or like coronaries, are particularly challenging from this point of view, but we can sometimes add the information to the surgeon to give a surgical clues, or to suggest what's going to be the best surgical approach in these patients. So the coronary anomalies, imaging targets, are those I listed today here. So I think it's very important, the evaluation of the ostium. So from the literature point of view, the ostial evaluation is the gold standard, as the CT is the gold standard. So there's no other technique that is able to evaluate the ostium, so non-invasively, of course. The ostium of a coronary is like the CT. So of course, screening or a routine echocardiography is able to recognize that there's an anomalous course of coronary arteries, but then CT is the gold standard for the non-invasive evaluation. Then there are some other invasive techniques that could add some other elements, but I think the most important aspects are the osteal localization, the interarterial course, and there are other elements that we can add, especially the morphology of and the length of the abnormal ostium in which we are usually trying to recognize intramural course. Then there are some in functional information like dynamic compression, so always changing the ostium during the systodiastolic phase, and the intermyocardial course for bridgings, for example, and other elements of functionality like ventricular function and ischemia viability are, I'm not going to talk about these two topics today. I will be focusing on these aspects that are more anatomical and more focused on the coronary origin and course. And just this images that's coming from a dear colleague from the US, it's Rajesh Krishnamurti, that is, he has been working on coronary anomalies for a long time, and is also introduced with other colleagues the possibility to show three-dimensionally the anatomy of the coronaries from the epicardial point of view. So and also the morphology, so the vessel view, so the intra aortic view of the vessel wall based on this 3D anatomical reconstruction. That is also very useful, and it's corresponding beautifully in many of the cases in using CT angiography with the surgical views. The importance of the coronary anomalies interpretation is to remind when you analyze and you evaluate some CT angiography data sets, is to evaluate the aspects of the osteomorphology. That is the main thing. So we will be seeing that some of the cases I will be presenting, that there is possibility to differentiate the morphology of the coronary arteries proximal course based on their shape. And this is very important to get the possibility, the chances to have intramural course or stenosis, and of course the position of the coronary ostium related to the other components of the aortic root, and of course the relationship between the two osteums, because the left side and the right coronary artery ostium, and of course that is important also to differentiate and to recognize the main diagnostic elements that are suggesting the presence and the length of intramurality. And of course, it's important to visualize it, to give a relationship of these courses with the other components, as we said, but in particular commissures. And of course, one of the main topic and aspect I won't be talking about this today is the dominance. So what is the main coronary that is supplying our myocardium? In particular, this is the case of hollow view. So there is an intracavitary view of the coronary anomalies. This is the right coronary sinus. So this is Valsalva, and this is the coronary ostium of the RCA, and this is the LCA here. As you can see, here is not originating from the in the right position, so it's not central like the RCA in the middle of the in the coronary sinus, but it's actually displaced and localized into the right coronary sinus, but above here, very close to the commissure, with a slit-like morphology of the coronary ostium, so you can't really see the lumen of the coronary arteries proximally, because it's squashed and reduced in caliber and in shape because of the intramural course. This is a clear example that we can have from the literature, and this is important to recognize some of the aspects when you look at the coronary ostium, particularly the relationship between the other ostium, and this is the case we just seen. So we have a separate ostium. This is the right coronary artery, and this is the left from the inside again. And in this case, those are separated, and the proximal course of the anomalous coronaries is usually intramural. Then we can have other different aspects and morphology of the ostium, and they can go from separate to adjacent. And in some cases, we can have some single ostium bifurcating in the aortic wall or bifurcating outside the aortic wall. So all these three possibilities are they can include the chances to have an intramural course. That is something that we want to recognize and highlight to the surgeon. I will present a case of anomalous aortic origin of coronary arteries. This is a 50-year-old lady that was symptomatic with epikinetic cardiomyopathy. So there's a 42% ejection fraction with some negative stress test at the nuclear medicine test. I will just show another what is the reconstruction we made from our Horus segmentation. So I won't show you the exact the entire process of isolation of this structure, but basically we cut it then with this crop to our imaging data set and reduce that to the aortic root. Then we apply the sort of crop of the aortic root anteriorly. As you can see, this is the entire aortic root. By just cropping and reducing, we are making an inside view of the aortic root and ascending aorta, from which you can clearly see that the right coronary ostium is in right position, and we have the left coronary. Apologies. I mean the opposite. So the left coronary artery is originating from the left coronary sinus, and this is the RCA that is originating from the paracommissural level, at the level of the sinotubular junction, very close to the commissure with the proximal course that is just behind this slit-like shaped ostium, and is coursing, of course, in between the pulmonary trunk here and the aortic root. So this is a classical case of anomalous aortic origin of the right coronary artery from the opposite sinus, in which we are beautifully visualizing the relationship of the two ostiums. So this is a clear case of a separate ostium in which the coronary arteries is coursing anomalously anterior to the aorta in between the two main vessels. Going back to my presentation, I will just show you some other case in which we can, of course, with our 3D tools. This is the Horus segmentation. It might be not as performing as other more powerful computers, but we can, of course, make some additional 3D volume rendering representation, including the pulmonary trunk and its relationship to the proximal course of the anomalous coronary arteries. Again, this is the intramural interarterial course, and this is another virtual reconstructions of a similar case in which we can beautifully see again the LCA and the proximal RCA course and its relationship to the aortic root, the commissure, and the aortic valve. Let me show another case in which we segmented we made let's say a virtual dissection of the coronary anatomy. That was very difficult actually, because it's a very small baby with a neonatal antenatal diagnosis of large coronary artery fistula, and we performed the CT angio on the very first day of and the very first day of birth. I will just go to the case, and in this case I will show you the proper process of segmentation. I don't usually work with Horus, and of course Dr. Gupta can be more skilled than me, but I'll show you just the data set here. As you can see, this is the axial view in which you can beautifully visualize there's a large coronary artery rising from the left coronary artery sinus, which gives rises to some branches, and is coursing into the ivy groove. Is very large. It looks like a large coronary sinus, but actually is a left circumflex that is sort of giving some branches before connecting to the right ventricle. So it's a large neonatal coronary artery fistula, and I will try to segment live these images. Hope it will work, because actually it's not easy to make it so quickly, but in this case we have a very clear representation of the 3D anatomy, and I will show you. So once you open the data set, you apply your 3D preset. I already prepared my 3D presets here. You can crop your images and reduce to the target area that you want to be focused on the anatomy.
Helio,
Yeah.
I think your 3D is not seen, so you have to switch the.
Okay.
I think, yeah. Yeah.
Thanks. Can you see that?
Yes, it's visible now. Yeah.
Okay. So basically, this is the anatomy of the already segmented. Again, we have the IVC. This is the right atrial appendage, and we have here. You can also switch to GPU, so the graphic processing unit, that can enhance your 3D visualization. This is the preset is a courtesy of Professor Gupta, and this is beautifully demonstrating the anatomy of the right atrium and relationship with the tricuspid valve. And if you look at the cavity of the right ventricle, you will be beautifully seeing the pulmonary valve, the insertion of the septomarginal bands, and this is a tricuspid valve from the inlet portion of the RV. In this case, we had a beautiful representation of the orifice of the large coronary artery fistula that is connecting directly to openly connecting to the right ventricle at the level of the basal slice, very close to the interventricular septum, just below the tricuspid valve. So this patient was evaluated with, of course, with conventional echocardiography and CT, and we, just because of this large and broad connection, the surgeon and the interventional cardiologist decided to go for surgical ligation of this large connection, trying to preserve all the branches of this large fistula. So this is the fistula just at the level of the left AV groove. And I think, again, we can, in this anatomy that is from a newborn, so very challenging to have a beautiful representation, you can also appreciate some aspects of the right atrium, for instance, the appendage or the triangle of Koch in this image, because we have all the elements, so the tendons of Torderose and the apex and the connection with the septal margin of the tricuspid annulus, that is sort of and in the middle we have the orifice of the coronary sinus. So I think I'll just go back to my presentation and show the other cases. So this is another case of large coronary artery fistula, again, that is connecting the RCA, so the opposite coronary at the same level to the basal inferior wall of the right ventricle. This is another interesting case. It's very difficult to segment it with Horus, so I will just show you some cases of the segmentation we currently do. So it's a 5-year-old boy that was being resuscitated for an episode of sudden cardiac death, cardiac arrest due to ventricular fibrillation, and we've done in this patient many test investigation. There were no other arrhythmias, no other findings from a arrhythmic point of view on MR. The only thing we spotted was a coronary anomaly that was like very rare, anomalous origin of the right coronary artery from the non-coronary sinus here. So we have here this left coronary artery, the left coronary sinus, right coronary sinus anteriorly, and this is the RCA that was originating from the proximal, from the non-coronary sinus. So with the CT, we gave all the details of this anatomy, and we beautifully demonstrated the relationship of the coronary ostium that was originating. There was a sort of eye takeoff of the right coronary artery just above the non-coronary sinus. Then we decided that was not enough to get information about the potential intramurality of these coronary anomalies. So we performed the virtual dissection, and we recognized that there was definitely a morphology of the ostium was slightly slit-like or oval in the middle between the two. And by segmenting with our tools and trying to make a surgical view and dissection, we recognized that there was a very thin walled proximal course of the coronary right coronary artery, just very close to the ostium, and we suggested that there was a proximal intramural course, very vertical, directing towards the commissure that suggested the potentiality that this anomaly was related or linked to the cardiac arrest. So the patient underwent surgical unroofing of this intramural course that was confirmed during the surgical operation, and was implanted with an ICD, of course. This is another case that we that presented as an asymptomatic 13-year-old boy, which was a diagnosis of anomalous LAD with an echo and CT, and we performed also myocardial ischemia test with our with nuclear medicine investigation that were resulted positive. So I will just switch to my Horus to show the segmentation of this case. I'll just go through 3D and connect. Let me know, Saurabh, if there's any issue in the connection.
Yeah, as of now, we are not seeing your screen.
Okay, let me just... Okay, can you see now?
Yeah, we can see now, yeah.
So basically, once we have the entire data set, we take our preset, the one we prefer, and I mean, I had mine, and Saurabh shared with me some of these tools. And as you can see, it's very easy to crop all the elements from and to focus on the aortic root. In this case, I will just go and from the posterior view of the aortic root. And as you can see here, there's a large ostium of the right coronary artery ostium that looks like broadened with the bifurcation. I can enhance our my rendering properties. And if you go anteriorly, we recognize that there is a right coronary artery anterior arising and the left coronary artery originating from the right coronary artery in a single coronary proximally. There's a large common ostium that is bifurcating just after just outside the aortic wall. And if you focus a little bit more, we recognize that the proximal course of the coronary artery in dissecting is not the epicardium. It's actually this red is representing the myocardium. So the proximal course is basically within the myocardium. So this is an anomalous origin of the left coronary artery from the right coronary sinus that is with this intraseptal course. So it's not interarterial. So the interarterial space is just in here. And the proximal course in this case is inside within the muscle and this just going below the pulmonary valve and rising epicardially just after this long course of the left main stem into within the intraseptal. In this intracavitary view, so in the hollow view, we can beautifully see that there's a common ostium and that is bifurcating just outside the aortic wall. And it means this is suggesting that there is no intramurality course at this level. And we publicate this case because actually we performed surgical correction because the ischemia tests were positive. And this is the case published in here. And as you can see how those images are clarifying that the proximal course of the LCA is within the myocardial tissue. This is the segmentation done with the other softwares. This is the positive test of myocardial ischemia. the patient underwent surgical debridging of this tract after removing, resecting the pulmonary trunk and translocating the pulmonary trunk more accurately with patch augmentation. Another case is a very interesting case of a kappa, because it's a 4-month boy with presenting with all the principal sign of heart failure related to anomalous origin of left coronary artery from the pulmonary artery. And those are the images, as you can see from the radiological images bidimensionally. You can see that the left coronary artery is originating from the main pulmonary artery, just very close to the origin of the right coronary artery here, and that the proximal course is sort of hook-like, so it's very tortuous and angled. It's very flattened at the level of the ostium within the aortic and pulmonary trunk. So basically, in this case, we managed to do segmentation of the aortic root and try to give a relationship between the anomalous course of the coronary artery with the aortic root, because there was a suspicion of intramural course of the left of the anomalous coronary artery. We'll just open the images and ask the if you see that. Can you see the images?
Yes, we can see that. Yeah.
Okay, as you can see here, this is a large severely dysfunctioning left ventricle and a large left atrium. And as you can see here, there's an anomalous course of the, it's nice to see the MPR views. You see the coronary artery is rising from the origin of the right coronary arteries here, and is sort of coursing with this hook-shaped origin and course of the proximal LAD. The portion of the proximal LAD, anomalous LAD, is very thin-walled and looks like it's very close to the aortic wall as well. So in this case, I think the suspicion is very high. And what I currently do in this case is just go to the 3D, try to segment this 3D as well, in a similar way that we've done before. And applying a different preset. In this case, I have a specific one. For instance, okay, that is. And again, you will have all the data sets segmented, and we have to focus on the aortic root and pulmonary trunk again. And this case is interesting because we can try to get into the cavity and to visualize the pulmonary trunk, and to see that this is the ostium of the pulmonary, of the anomalous coronary artery. It's very hard to segment in live. Apologies. Okay, now we are into the aortic root. Sorry, there was I have to open again, but actually just jumping this segmentation because it's very difficult and I need some more. I think I'm lacking of memory with my computer connecting to Zoom. And I think that I will just show you the picture from here. Basically, the intramural course is a very thin wall when you segment the anatomy.
We are not seeing your presentation.
Basically, from this previous segmentation tool, this is the LID from the aortic side, and as you can see here, from the segmenting this part, you will sort of seeing the anomalous LID from the aorta, suggesting that this part of this wall is very thin walled and is possibly connecting so the vessel is possibly intramural at this level. So we'll just conclude with this very interesting case. This is a 3-month-old infant with the bronchodysplasia and mild oxygen dependency. And there was a suspicion of the echocardiography of the anomalous origin of right coronary artery. We performed the CT, and we couldn't really see any coronary ostium from our virtual dissection at the level of the coronary sinus. Is basically because this patient had a total anomalous origin of both coronary arteries from the pulmonary artery. And this is the anomalous origin of the LAD from the anterior facing sinus, and this is the right coronary artery that is coursing anterior to the aorta. And this is the published case in the European Journal, because of course we had this patient underwent the surgical reimplantation of both coronary arteries originating from the anomalies from the pulmonary trunk. So thanks very much. Any questions?
Thank you, Dr. Aurelio. It was a very good presentation of, very unusual cases. So any questions from the audience?
I don't think anybody will talk.
So in coronary evaluation, do you prefer these kind of virtual reality, the VRTs and virtual dissection kind of thing, or you go for raw image analysis?
I usually do conventional analysis, and I mean, if there's any surgical indication, I prefer to integrate with this virtual representation. I think the surgeon, they like it very much. They find it very useful, and sometimes we add some additional elements also for the diagnosis. When they are very small, we found it very useful. Now we routinely perform as they do and other colleagues do in the US.
Yeah, I think more is about the comfort of the people who are seeing. So unlike radiologists, the cardiologists and the cardiac surgeons are not so used to seeing those multiplanar images. So they'll be very happy if if somebody can give them that 3D kind of images. And that's what I liked about this virtual dissection, because it gives you that whole of the heart in your screen, and you can manipulate and see the way you want.
Absolutely. I think from my perspective, the coronary anatomy, especially, is a there are very small structures, and I think it is very easy to transfer, especially the coronary, the ostium position, to the surgeons and to the cardiologist. Sometimes you make the diagnosis anyway, and when you look at 2D images from echo, from CT, you have a clear image that is a coronary anomaly. But then when you want to say, okay, this ostium is very close, is that adjacent, is separate, is it slit-like, is it oval or whatever, you can do multiplanar formatting and it works. But when you want to have to give clues to the surgeon to what's going to be or to simulate or to understand better what is going to be the approach, so the unroofing, how long it's going to be, on what is going to be the appearance from when I will be in the theater, I think is an additional value. Of course, again, this is not this is sort of validated from the coronary anomalies, especially from anomalous origin of coronary artery from the opposite sinus. I don't know if Sasha wants to.
In structural heart diseases, it can provide guidance to the interventionist who is performing the procedure. What may be the working view? Because it can replicate your RAOs, LAOs, cranial, caudal tilt. So it kind of gives a very good representation of what you are going to see in the lab. So there is a question in the Q&A. Can I answer that?
Hold on.
Hello, Dr. Aurelio, am I audible?
Okay, the coronary. Okay, I mean, the question is, can you identify the coronary bridge compression? I mean, as I said at the beginning of my presentation, this was not on the dynamic compression of the coronary of coronaries, especially so all the functional aspects or dynamic aspect of the osteum of the coronary course is not in this presentation. Is not the topic of today. However, I have to say that some of the bridging compression can be evaluated with a retrospectively gated coronary CTA. That is a sort of coronary CT that it covers the entire cardiac cycle. So we acquire all the data in different cardiac phases. So we have the systolic phase, the diastolic phase. This is, of course, is a technology that is a common way to acquire the data that is sort of exposing to a higher dose of radiation, but at the same time gives us the anatomy and the functionality and the dynamic evaluation of the coronary course, especially the bridging course. I've done this. Of course, the coronary compression, it's very hard to prove, and I haven't seen that. I haven't seen that yet on a coronary CTA. I don't know if in your experience, Saurabh, if you have any case of coronary compression in a bridging, but I don't think I haven't seen that so far.
Yeah, we can make a guess, but I think the credibility of that information won't be great. That's what I would say. So there is another question which says that how to save the images which are generated by Horus. So if you allow me to share my screen once, I can just show that. So if we go, I'll show. So this is the 3D image, which suppose we are happy with the image. I think this question comes from Dr. Sushil. He's a good friend of mine from Delhi again. So if you are happy with the image, we can just go from this file. We can say export, and this allows us to export in TIFF format or JPEG format. We can do that, and then wherever you want, it can be saved as you do for any other thing. Now, if you want to do a kind of video where you want to show what all can be possible, like the video which I showed, the virtual demonstration of sinus venosus defect. So if you want to create something like that, then you have to use the fly through function, where you can say add fly through point, and then you can keep adding these points. And once we do that, the system will create a fly through. We can add another point here, similarly here. So I'm just doing a very rough one just to show how it can be done. Then we say, okay, compute. So it will compute and we can see. So this is how we will be able to see different views from the same data set. So this is the fly through function, wherein you can create a set of images, and you can, this cube, direction cube, will keep telling us in which projection we are. So this can be useful in demonstrating to anybody you wish to share the data or image with. I hope I have clarified that question.
Yeah, you can also zoom and change you can make any change from one frame to the other, and then it will sort of interpolate the data and make it, and you can make a video, you can make any format you like, also DICOM image you can store in your packs. I think that is a very powerful tool.
Yeah, and storing can be done as Dr. Aurelio said. It can be saved as DICOM, then it remains within the Horus system, or it can be exported as usual image formats or movie formats.
Perfect. I think we finished. I don't know if Sasha wants to conclude the session. Otherwise, we could say hello, everybody, and thanks to the audience for attending this session. Thanks, Saurabh. That was excellent overview on this too. And and I really enjoyed to segment these my coronaries with Horus. I don't routinely do, but it was a good training, and I think it's something that could be replicated anywhere else.
Yeah, I'll be happy to help if any of the attendees would like to approach or try and seek suggestions regarding this. I'm sure everybody can do it, but yes, if there is a way I can help, I'll be very happy.
Thank you.
So I think Dr. Shasha is not here. So we thank on behalf of Congenital Heart Academy also for the participants who have joined. So thank you very much, and we'll end the meeting. Thank you, Dr. Aurelio.
Thank you very much, everyone. Bye-bye.